All right, good morning, everybody. Welcome back. Good to see you all. GIM Grand Rounds this morning. We have Dr. McDermott, Professor of Medicine in the Division of Endocrinology. Dr. McDermott was in medical school May, and he did his residency in internal medicine and published in endocrinology here at the Simmons Army Medical Center. He's speaking today about a very common condition, type 2 diabetes, that nevertheless seems to be continuously evolving. It remains a challenge, certainly for me, and probably for many of us. I asked him to speak about tips and tricks in managing type 2 diabetes so that we can all benefit from. Dr. McDermott, pleasure to have you.
Zero. Do we have somebody?
You're being detected. Yeah.
Okay, very good. Well, Brandon, thank you. Thanks for asking me again. Nice to see all of you again. It's good to have an update on diabetes fairly often because it is a fast-moving field. So I don't have any conflicts of interest, and the learning objectives. Really, I just copied this email that Brandon said. He said how to prioritize GLP-1s versus SGLT2s, prescribing GLP-1s for weight loss due to the insurance issues. When do we need to prescribe needles for certain things? Just really, pretty practical things. When to refrigerate diabetes drugs. What are pet peeves and mistakes that I see people make? When and how to prescribe and use this PGM. And so I'm going to try to cover all of those. It would be worthwhile just to review. I think anytime we talk about diabetes, pathophysiology, some of the different medicines are directed against one or another of the pathophysiologies of diabetes. But when we have hyperglycemia, the contributors are first excessive hepatic glucose production. So when people wake up in the morning with an elevated glucose, that's because their liver made too much glucose during the night. It wasn't because they ate too much last night. That goes away after 4 hours. The liver makes glucose in the fasting state, waking up with high fasting glucose, and because of excessive hepatic glucose. People with type 2 diabetes have insulin resistance, which means when they eat a meal and their insulin levels go up, and insulin should drive glucose into muscle and fat tissue and other various tissues, but mainly those two. And if there's resistance to that, a certain amount of insulin is not as effective as it would be in someone without diabetes. People often have this excessive hepatic glucose production and insulin resistance for many years without having diabetes or with only having pre-diabetes because they compensate by making a lot of insulin. But eventually those beta cells start to deteriorate from all the stress. Once insulin secretion drops off below where it needs to be for that person, they develop hyperglycemia. We've also learned that the signaling system from the intestine tell the pancreas how much insulin to make. You shut off glucagon, called the incretin system. It has some defective signaling also. And so those are some targets that we have seen researchers develop therapies for. So let's talk about the physiologic-based therapies that we have. What do we have that reduces hepatic glucose production? That's where metformin works. It's the major mechanism of action of metformin. We have medications that act on muscle and fat, isolodine. The main one we have now is pioglitazone. It's probably the single most underutilized and very effective medicine that we have. Nobody seems to use that much anymore. It's very effective still. It's about the same potency as metformin. We have medicine to stimulate insulin secretion no matter what the glucose is, and those are the sulfonylureas and glitamides. So if your blood sugar is 80, you take 5 you make insulin and get a low. So that's insulin or glucose independent insulin secretion, whereas the incretin system, these incretin medicines, they do stimulate insulin secretion, but they do so in a glucose dependent manner. They only stimulate insulin production when your blood sugar is high. So what do we have to stimulate this insulin system or incretin system? We have the GLP-1 receptor agonist that we'll talk about more. We have a new GLP-1 GIP receptor agonist. We have the DPP-4 inhibitors. These all act through the incretin system. We have bile acid resins with colesevelam used for treating cholesterol in the past. Actually lowers A1C at about 0.8%, so it's approved. Colesevelam is a diabetic medication. And then we have glucosidase inhibitors. acarbose and ribitol that just inhibit glucose absorption. They're often used in people that have reactive hypoglycemia as well. We have these medicines that act on the kidneys and increase urinary glucose secretion of those SGLT2 inhibitors. So that's the lineup. I just want to show you where they all work, so you can see how we might use some combination together. One of the keys I'll talk about is not to use a DPP-4 inhibitor, the GLP-1 receptor agonist. They do the same thing. They're wasting money and not getting any benefit from it. So try not to use multiple drugs in the same category. Okay, so let's review physiology briefly so you can see why we're so enthusiastic about these meds. When you eat a meal, your intestine makes incretin hormones, and the two main ones of interest right now are glucose, like or glucagon-like peptide 1, GLP-1, and this new one, although it's not really new, we've known about GIP since the 1970s. It used to be called gastric inhibitory polypeptide because it slows gastric emptying, but because it has a lot of other actions, and one of those is glucose-dependent insulin secretion, GIP's name was changed to glucose-dependent insulinotropic peptide. So they're very similar. What they do is when you eat a meal, these hormones are secreted. They actually circulate for about 2 minutes before dipeptidopeptidase 4 breaks them down. But during that time, they go to the pancreas. If the blood sugar is normal, they actually don't do anything. But if the blood sugar is elevated or rising, they stimulate insulin production and they inhibit glucagon secretion. So they do that in a glucose-dependent manner. Pancreatic blood supply goes directly over to the liver, and that's what shuts down hepatic glucose production. These medicines also slow down gastric emptying, so the food stays in the stomach a lot longer. That's one way that they inhibit appetite. They also have a direct effect on the central nervous system to suppress appetite in one center of the brain and to enhance satiety in another. So two different CNS actions. So these hormones are very potent and have a lot of beneficial effects on glucose and nutrient metabolism. But we have to learn how to use them because their native state only lasts 2 minutes of circulation. So incretin physiology or incretin-based therapies have been all about how to engineer medicines that either inhibit the breakdown of GLP-1 or prevent GLP-1 from being broken down by changing the structure of the molecule. So we have these GLP-1, GIP, and receptor agonists that have amino acid substitutions that make DPP-4 unable to cleave them and break them down. This prolongs the duration of action of native GLP-1 and GIP. And then we have DPP-4 inhibitors. These are about half as powerful, and they directly inhibit DPP-4 so that your own GLP-1 lasts longer. Again, those are the names down there. And GIP, just to repeat it, because it's kind of new in our lexicon now, glucose-dependent insulinotropic peptide. Okay, so what GLP-1 receptor agonists do we have? First one that came out was Byetta, which you had to give us a shot twice a day. And then Victoza came out. This was a real hit. It's a once-a-day injection. Don't forget about this one. It's very cost-effective. It's covered by most insurance companies, and it's a once-a-day injection with cardiovascular data as well. Lixazinotide is once a day. Durion once a week. Then we have the ones that we use more often, dulaglutide once a week, and semaglutide once a week. And don't forget that semaglutide comes in an oral called Rybelsus. If you use Rybelsus, it's got very specific instructions on how to take it. You take it on an empty stomach with no more than 4 ounces of water, and you don't do anything for an hour. I've seen a number of patients that have been taking Rybelsus and it didn't work. And I said, well, how are you taking it? They just take it with their other pills. It's actually not absorbed through the intestine. It's absorbed through the stomach. It's got an adhesion molecule on it that makes it bind to the gastric mucosa, and it's absorbed right through the stomach. And it takes a little while. And so the idea here is very physical. It sits there, and if you cut other pills or food, it just knocks it off. And it goes down into the intestine where it's not absorbed. Okay, so if you're giving somebody Rybelsus, you don't want to take shots, make sure they're taking it correctly. And that's probably the most common reason that we see that Rybelsus doesn't work. Otherwise, it does work, just like Ozempic. It's just an oral. And then we have this new GLP-1 GIP combined receptor agonist called tirzepatide from Mounjaro that's also given once a week. So we'll talk about these. So this is the structure of GLP-1, and this is the structure of GIP, and you can see that they're just very similar. DPP-4, that's characterized here or cartooned here as scissors, cuts in the exact same place. So these are very similar molecules. So it's not surprising that they, even though they bind to different receptors, they have fairly similar actions. So the GLP-1 receptor and the GIP receptor are very similar. When GLP-1 binds to the GLP-1 receptor, that stimulates insulin production, suppresses glucagon, suppresses appetite, and slows down gastric emptying. When GIP binds to its receptor, it does exactly the same thing. So a GLP-1 receptor agonist binds only to the GLP-1 receptor and has those activities, and we're very familiar with this. We stimulate insulin, but only when glucose is elevated, and that's why the GLP-1 receptor agonists have a very low risk of hypoglycemia. They suppress glucagon, which is an important counter-regulatory hormone that elevates glucose. When you suppress glucagon, you lower glucose, and they suppress appetite and suppress gastric emptying. Tirzepatide is a dual agonist that binds to both the GLP-1 receptor and the GIP receptor. It has the same activities, but it's just sort of a GLP-1 receptor agonist on steroids. It just has significantly more potency. So, and you're familiar with a lot of these. One of the questions Brandon asked me is what do we do about using these medications for weight loss? There was a run on these. You know, we had shortages of all of these medicines for about the past 6 to 9 months because so many people were using them for weight loss. They're expensive, but a lot of people are fine with that, figuring the cost of these medicines may be similar to what it costs to some of the health clubs in town. All right, the sodium glucose transporter 2 inhibitors, SGLT2 is located in a convoluted tubule, and it's responsible for about 90% of glucose reabsorption. Glucose is filtered in the glomerulus, and it comes down through the tubules. About 90% is reabsorbed in the proximal tubule by this one protein, SGLT2. So the kidneys filter and absorb about 180 grams every day glucose. And as I said, SGLT2 is responsible for 90% of that reabsorption. Other proteins, the other 10%. A normal person is not going to have glucose in their urine unless their blood sugar exceeds 180. But if you take an SGLT2 inhibitor, you'll have glucose in your urine once your blood sugar is over 80. Okay. Now remember that carbohydrates are 4 calories per gram. People lose about 80 to 100 grams glucose per day when they're taking SGLT2 inhibitors. They lose that much in their urine. So that's about 320 to 400 calories per day. It's just being lost in the urine. That's why you not only lower glucose, but they help promote weight loss. So blood glucose goes down, weight loss occurs in most people. They don't cause renal damage because the blood glucose, which is what the glomerulus is exposed to, is actually lower, and they improve intrarenal blood flow and reduce intraglomerular pressure, similar to what the ACEs and the ARBs do. But they do increase urinary exposure below the kidneys to more glucose. So there's more GU infections and UTIs. So one reason that you may not want to use these, or that you may have to stop them, is that people are having recurrent yeast infections or recurrent UTIs. The UTIs are not as common, but the yeast infections are fairly common. We have 5 of them. There's one that was more recently approved. So we have canagliflozin, dapagliflozin, pertugliflozin, and bexigliflozin. And those are their names and their doses. The top 3 are the ones we use most often. They're most often approved by insurance companies, and these are the ones that have the cardiovascular, heart failure, and renal data, whereas these last two are lagging in that type of data. Remember that these medications can cause a condition called euglycemic DKA. Before these came out, we saw euglycemic DKA mainly in pregnant women. And what that is just DKA in someone whose blood sugar doesn't meet the usual criteria, which is a blood sugar over 250. So pregnant women can have a blood sugar of 150 and have DKA. So that's how that term came about. It's not really euglycemic, those aren't euglycemic, but it doesn't meet the traditional DKA criteria. People who take these medicines can develop euglycemic DKA. And the most common precipitants for this are fasting. So people come to you and say, I want to do intermittent fasting. What happens when you fast? You develop ketosis. Whether you're doing fasting every other day or time-restricted feeding, when you're not eating, you're developing ketones. When people are NPO for procedure, they don't eat, they get ketones. When people are on a ketogenic diet or a very low carb diet, they make ketones. And so these also cause people to make ketones by a different mechanism. If people are going to do intermittent fasting, if they're going to be NPO for a procedure or because they've just gotten admitted to the hospital, or they're going to go on a very low carb diet, they really need to stop their SGLT2 inhibitors. And we had a patient not too long ago that came in for a surgical procedure and got euglycemic DKA because his SGLT2 inhibitor was continued while he was NPO for several days. And so that was one of the QI or M&M cases that we recently reviewed. Okay, so just to review what other data we have is that
Is euglycemic DKA as dangerous as the garden variety?
well, they tend not to have a significant volume depletion, but it can be tricky to treat. And one of the reasons for that is they're already under 250, so when you start giving them insulin, you have to give them glucose right away. What you're trying to do is get rid of the ketones. And so the treatment for this, as opposed to DKA, where we've got good protocols, we start insulin, and then once they get under 250, you start glucose and insulin. Here you've got to start insulin and glucose at the same time. Right. And I've seen that just, I was talking to an ED doc in the Springs, a patient complained that he had this, and he wouldn't do that. And she left AMA, went home and drank a bunch of Gatorade, gave her own insulin, and treated her own DKA. So I think it's easier than sweet. But you have to recognize it too. So these people are asking about it. The guy we had in the hospital was, they thought maybe he had lactic acidosis because he had some bowel problems and he had actually euglycemic DKA from staying on an SGLT2 inhibitor. So I think the danger of it is that we just don't recognize it sometimes. So to review the effects on comorbidities, CKD benefits are proven. Rid of this compound. Sure. I don't know how to, okay. Sorry, I don't know how to get rid of the top banner. CKD benefit is proven with these SGLT2 inhibitors and with these GLP-1 receptor agonists. Okay, so all of those have benefit in people with CKD, whether it's diabetic CKD or not. The SGLT2 inhibitors have been used in people who don't have diabetes, just have chronic kidney disease. Nephrologists are starting to use them quite often. Anyway, there's good CKD benefit proven for both classes. Cardiovascular disease benefit has been proven for the SGLT2 inhibitors and also for the GLP-1 receptor agonists. Now, I don't have tirzepatide on here because the studies for tirzepatide have not they're underway. You think it will have a cardiovascular benefit also, but it just hasn't been proven. It got to prove without cardiovascular data. And then heart failure benefit has been well shown for the SGLT2 inhibitors, including HER2 gliflozin, but not dexagliflozin, the latest one. So thinking about your patients and some of the comorbidities they have, choosing the right medication to treat not only their glucose, but their comorbidities is important. I thought this would be an important table to construct, to just compare the SGLT2 inhibitors with the GLP-1 receptor agonists. In the first thing to consider is that the GLP-1 receptor agonists are much more potent when it comes to glucose reduction. So if you have somebody that has an A1C that is 10, you're trying to get it down to 7, an SGLT2 inhibitor is probably not going to get you there. Okay. So you have to look, and we'll talk about this as we go on, what sort of potency do you need? So the GLP-1 receptor agonists have much more, or about double the A1C reduction and about double the weight loss. Hypoglycemia risk is low for both of them. There's a CKD benefit from SGLT2 inhibitors, and it was a secondary outcome in many of the GLP-1 receptor agonist trials, not a primary outcome. So I put a question mark here. We think there's been a CKD benefit from GLP-1 RAs, but it was never a primary outcome in their studies. It was always secondary. Cardiovascular protection from both, heart failure protection, the SGLT2 inhibitors, maybe with these, we don't know. But GLP-1s clearly benefit people with non-alcoholic fatty liver disease and NASH, so that's another reason to consider those. The risks I talked about, GU infections and DKA, possibly pancreatitis with GLP-1 RAs. What about in CKD? If someone has CKD and you use an SGLT2 inhibitor, their glucose benefits diminish the lower the renal function is. If you use these in somebody with an estimated GFR of 35, their glucose reduction is going to be minimal, but their kidney protection is still going to be very good. So it doesn't mean you don't use them, but you don't get as much mileage in terms of glucose reduction, the lower the renal function is. There was a good glucose benefit even in CKD with GLP-1 RAs. Tirzepatide, just to give you a little bit of perspective, the A1C reduction we see from tirzepatide is 2.5 to 2.8%, and the weight loss is 20 to 50. That's similar to some of the bariatric surgery procedures you see.
Do you see more GI side effects with tirzepatide than the other GLP-1s?
Haven't used them long enough to know for sure, but so far the answer's been no. I haven't really seen them. And I've picked people who had side effects on one of the others and put them on tirzepatide, and they haven't had side effects. I think the key is to start at a low dose and build up gradually. So tirzepatide starts at 2.5 milligrams weekly, and then there's 5, then there's 7.5, 10, 12.5, and 15. I think people start on 5 and 7.5 pretty regularly, and that may be why some people are getting some side effects. And I think it's better to be patient, start people on the lowest dose, wait a month. In 3 or 4 months, you'll be happy you did that. If you start too fast, it's too high dose, just like with those inhibitors, you listen to the other time.
What's the story on GLP-1 receptor agonist pancreatitis? Because I've seen a couple of patients who had pancreatitis, the cause wasn't clear, they happened to be on this commonly used drug. There was speculation about that the drug was driving them potentially or that benefit. And then if there's a table that they have a drug-induced pancreatitis list 100 drugs that can do it, the GLP-1 receptor agonists do not appear in that list. And so I've just been uncertain about what to make of this possible system.
Well, you and everyone, that's a good question. The first thing is that in clinical trials where there was an increase in pancreatitis in people that were using GLP-1 receptor agonists, it wasn't at all clear that that wasn't due to the diabetes and hypertriglyceridemia and the obesity. People with type 2 diabetes already have a 2-fold higher risk of acute pancreatitis. So it wasn't clear that these were causing it. But it does come up. People get admitted with pancreatitis are on this, that get stopped, by the inpatient folks. I've had people come back to me and say that I was doing well on this. I'd rather not stop it. And I can tell you there's at least 5 people that I put back on after an episode of acute pancreatitis, and they have done fine. So it's an unanswered question. I think you have to use your, best judgment on that. And I would at least tell people we're not sure that this caused your pancreatitis. It may have, and I'm willing, at least I am, I'm willing to put you back on this, but I want you to know this information. And of the people that I have done that with, I've not had another episode. And I think I've heard that from other people around the country, but it's definitely something you have to consider. And if you're being very careful about risk management, that may not be something you want to do. But they're so effective, it's really tempting to come back to them.
You mentioned the clinical trials was clear that these drugs were causing it. Was it higher in the GLP-1 arm than the placebo
It
arm?
was higher in the GLP-1, so that is why that came about, but it was small, and it was true also for the DPP-4 inhibitors. There was also, one paper that suggested maybe there was some pancreatic tumors that occurred, pancreatic carcinoma, maybe neuroendocrine tumors, and that really got dispelled. That's not been borne out since then.
Still on TV.
Pardon?
It's still on TV.
Yeah.
So for some of the neuroendocrine tumor, you would be comfortable putting on.
I'm comfortable putting these people on people who have thyroid cancer. The only type of thyroid cancer that has been shown to be possibly stimulated by these is medullary thyroid cancer, which is about 5% of all thyroid cancers. So if somebody had medullary thyroid cancer or a family history of medullary cancer, I would probably not put them on one of these, or at least I would discuss it with them. But your garden variety medullary carcinoma and follicular carcinoma, those are not a problem. There's one paper recently now that said maybe there is. Maybe there's an increased risk of all types of thyroid cancer, but the paper was done very poorly. It included a lot of very questionable data, and it's under a lot of criticism right now. So I still think, thyroid cancer, and pancreatic tumors are fine. There's really any risk.
Couple questions coming in from the online folks. Do you ever think that metformin shouldn't be a first-line drug? Patients who otherwise can tolerate it, GLP is okay, because they have other comorbidities where you're just skipping metformin and you're putting them straight on to one of these other agents.
Metformin still is a good first-line drug just because it's very cheap and it's very effective, and it has long-term safety, efficacy data, and it probably has cardiovascular and renal action that's been shown in sort of meta-analyses in multiple trials. It doesn't have much in the way of weight loss, and so a lot of people in the diabetes field consider the GLP-1s, the SGLT2s, and metformin all going to be first-line drugs. Pick one. Certainly, cost effectiveness, metformin is going to be more cost effective, and you're going to get more mileage out of metformin plus another drug. If you got somebody with an A1C over 9 or 10, you really need a little bit more firepower. So I think metformin has been replaced as the central primary drug that we use, and then everything branches off after. You either add on to metformin, or if you get a metformin failure, you use other things. I think GLP-1 RAs can be used as primary therapy.
There's one other question here. Is there an increased risk of gallbladders, GLP-1s that could be predisposing to pancreatitis?
Yes, there is increased cholecystitis and gallstones with GLP-1s. So that could also be part of the cost. Okay, so this just looks at GLP-1 RAs and the SGLT2s in terms of different risks. These are the cardiovascular outcome trials, just to show you MACE. Both GLP-1s and SGLT2s have positive benefits. Cardiovascular mortality, they're similar. Myocardial infarctions are similar. For stroke, GLP-1 RAs seem to have better data. Total mortality, pretty similar. Hospitalization for heart failure, so that's where the SGLT2 inhibitors have superiority. And kidney outcomes, the SGLT2s probably have stronger effects than the GLP-1s. So to start with, when you're going to pick a medication, I think the first thing is to choose an agent that has adequate potency. So we often see people that are sent to us with an A1C of 10, 12, 13, greater than 14. Choose an agent that's got adequate potency. So the only ones that really can lower A1C by 2% or more are insulin, GLP-1 RAs, tirzepatide. Usually those are given with metformin to start out. So somebody comes in really very poorly controlled. I used to start metformin plus insulin. Now that the GLP-1 RAs are out, I can start metformin plus a GLP-1 RA or tirzepatide. But usually with metformin. And remember that once people get over their glucose toxicity, if you started insulin, you may be able to stop it eventually. So if you need modest A1C reduction, These medications here will give you 1 to 2% metformin, albendazole, sulfonylureas, still medicine that are effective, and then the 3 that I mentioned before. And then if you get just mild A1C reduction, the SGLT2 inhibitors and DPP4s. So just having an idea of their differences in potency, I think is important when you're looking at your medicine that you want to try.
Is there much of a role for DPP4s anymore?
I haven't prescribed one in 5 years. I think they were very oversold in the companies that make them. And the A1C reduction typically is about 1.6 or so, right around here. They don't have any data for cardiovascular or renal protection or heart failure. In fact, one of them has, some data on increased risk of heart failure. So I don't use the DPP4s. I think that, the attraction to them was that they rarely cause any side effects. So you can put people on them and they don't, probably call you back, see them sick in the stomach. They're probably not going to get much better. So our pharmacists were hoping to be able to put some sort of a hard stop that when you try to order a DP4 and say don't do this, they're not very effective. We weren't able to do that. I don't use DP4.
Is there an A1C at which you feel like that's correct?
When your A1C is over 12%, typically that's the level where there's so much glucose toxicity. What glucose toxicity means is glucose is so high that the beta cells are just depleted of all their stored insulin. And the cells that are supposed to respond to insulin are depleted of their glucose transporters that pull glucose into the cell. That would be muscle and fat. And the only way to restore that is to get the glucose under control pretty quickly. So traditionally, before the GLP-1s came out, over 12% or over 11%, you always do the insulin. I have been surprised, and now that I still see people with greater than 14, I think they need to be on insulin. But I have seen some people that just get put on a GLP-1 and they get better. And they come back in when they're A1C. We've had one very recently, one of our fellows saw that had an A1C 14, put them on a GLP-1, came back in 3 months, A1C 7. That was it. A lot of weight loss on top of that. But you have to titrate up gradually, so you're not going to get that immediate control. If somebody's symptomatic, polydipsia, polyuria, and you put them on the lowest dose of GLP-1, it's not going to work for a month. And so I think, starting insulin, if somebody's symptomatic from polydipsia, polyuria, blood sugar, and I would say right around 12% or so, most people need to be on insulin, but thought that, hey, let's just get this under control fast. And then see if we can get you off of it and replace it with a GLP-1. But if you decide on a GLP-1, we've had some actually pretty good experience. But can't give you just an absolute answer.
With more data on the effectiveness of the GLP-1s, are we seeing better insurance coverage? We still have a lot of patients who can't afford it, or they're Medicare Part B, and then they get 2 months and then they don't.
We're getting better coverage. Medicaid covers language items. So we are getting better coverage. But sometimes when you get a denial, or you get an approval, but the copay is $500 or $600, which drives me crazy. They're very effective. And somebody says, this really worked. I lost 10 pounds. Everything's I'm paying $500 a month. It's my copay, and they don't want to keep doing it. And so I've had to stop it just for that reason. So, but it varies. Sometimes people say, no, it's covered completely. I think you just have to play with the insurance companies and see what you can get. But I have seen better coverage than not adequate coverage in many cases. Remember that people don't want to gain weight. They want to lose weight. These categories over here, I want to talk about that, cause weight loss. Metformin and DPP4 inhibitors are neutral. Insulin, sulfonylureas, polydipsia, we did not all cause weight gain. So if you put somebody on insulin because their A1C is over 14, your goal is to get them under control, but they're probably going to gain some weight. And that may be another reason why you want to tell them ahead, you just need to get this under control. We'll put you on some, more effective long-term medicine that may help you lose your weight. Hypoglycemia is just as harmful, more harmful to the brain, with hyperglycemia. In fact, there's a much significantly increased risk of dementia in people with recurrent hypoglycemia. So recognize the ones that cause hypoglycemia, insulin, sulfonylureas, and glutamides. The rest of them actually don't. So you may need to use insulin temporarily in somebody with terrible control, but if somebody's having hypo, don't lower their metformin dose. You know, look at, are they on one of these and reduce the doses of those and try to get them on. They're having a lot of hypoglycemia. And then for as far as cost, even though I've given you a lot of good advantages, as Rita just said, these can be really expensive. Low cost metformin, it's less than $5, use it for 3 months. Sulfonylureas, how good is all in that category. And human insulin, NPH and regular, often work very well for people with type 2 diabetes, not type 1 though. And they're very inexpensive. So these are $25 a bottle. According to the most recent government reports, insulin can't cost more than $35 a month. So even the analogs may be now more affordable. But if somebody can't afford their analog insulin, remember the human insulins are a lot less expensive. Then choose the medication with the demonstrated comorbidity, as I've said. If they have CKD, if they have CVD, if they have heart failure, pick a medication. It's also going to benefit that. So what about insurance issues? The GLP-1 analogs are not covered by all insurances if you use them for obesity, but sometimes they are covered. And there's several patients I have that put on these just for obesity, or who have type 1 diabetes and were overweight, and they get covered. And I don't know how to predict how that's going to happen. It's worth trying though. I think if you're trying to get someone to lose weight and they don't have diabetes, it's worth trying to prescribe them. A prior authorization request might be needed. Here's something I do though on all these people. If they're obese and they don't have diabetes, I try to see if I can find any evidence of diabetes. I'll go to A1C, get a fasting glucose. I'll do a glucose tolerance. I'll tell them, avoid a cinnamon roll and some pancakes and then go to your blood sugar 2 hours after. If that blood sugar is over 200, you know, I hate to give somebody a diagnosis, but they do have diabetes. So that's, you know, you ask for tips and tricks. That's one of them. Interestingly, you know, Wegovy and Ozempic are well covered in the Veterans Administration. So if you have a patient that's a vet, you might give them a prescription to go over there.
Are any covered for pre-diabetes?
They're not. They're not. And those are people particularly, you know, like if their A1C is, and these are people that I'll particularly do these things. So I'll do a fasting, I'll do a glucose tolerance test or just a really high carb breakfast and tell them to get a blood sugar 2 hours. See if I can get some value that equals diabetes, and that way I can get it covered.
Mike, just adding to the anecdotes, I've had people for weight loss who Wegovy's not covered, but Ozempic is. So if Wegovy's not covered, I'll send it in for Ozempic, and sometimes it is, and it just makes no sense to me when they don't have diabetes, and that's what the indication is, that the insurance will cover it anyway.
Yeah. I had someone that went to the Ancient Health and Wellness Center the other day, and I have not been able to get a GLP-1 covered, and they started this person on Wegovy and got it. You know, I sometimes think it's
Depends on
sitting at
things,
the desk
exactly.
doing that prescription.
Yeah.
When do you need to prescribe needles if you're injectable? If you're using an insulin pen, you always need to do that. The short-acting GLP-1 analogs, which are those. But you don't need to write prescription for needles. The long-acting, but weekly GLP-1 analogs, glycotyde, semaglutide, and tirzepatide. So we made in our preference list, Jenny Madrid helped us do this. We put together everything that, you know, you just click it and, you know, if you're ordering glycotyde, it doesn't have needles attached. If you're ordering one of these like liraglutide, it will have needles with it. You might want to do that on your reference list, but all insulin pens and the short-acting analogs, GLP-1s, all need prescription for needles. What about medicines that need to be refrigerated? All injectable diabetes medicines need to be refrigerated until they're opened. And after opening, they should be kept at room temperature. They can be refrigerated. They shouldn't be kept in cars. blood compartments. But typically they're good for up to 45 days at room temperature. If you're concerned about that, or they're pushing it at that 45 days, or you're not sure, how warm the room is, refrigeration is still a good idea, but you need to keep them refrigerated until they're open. Room temperature is fine after that. Couple of just things that I noticed that I think, impairs our ability to treat diabetes appropriately. So starting metformin at a full dose is not a good idea. 1/3 of people won't tolerate metformin at full dose. We start at 500 milligrams once a day. It doesn't work, but it doesn't hurt. People can tolerate that. And then we increase every week. We build up by 500 milligrams more every week over 3 or 4 weeks. And if you do that, 90% of people will tolerate it. So when I see people that say, "Oh, I couldn't tolerate metformin," I'm not necessarily dissuaded to try metformin again, because they may have been started on 1,000 milligrams twice a day. Don't put them on 500 milligrams. That works for ketosis, but it doesn't work for diabetes. So start low and build up over 3 to 4 weeks. Another mistake is to use a GLP-1 analog plus a DPP-4 inhibitor together. They both act on the same pathway. They're not additive, except for their cost. Starting with basal insulin, but failing to titrate up the dose. A lot of times people will tell me, "Yeah, I put me on insulin years ago. It didn't work." How much did you put you on? No, 15 units. The average dose Lantus that a person requires is 40 units. Okay, that's the average. And so we don't start people on 40. We start them on 10 or 15. We give them an auto titration, increase it every 3 days until the blood sugar is between 80 and 130 in the morning. If they never got up to a dose of around 40, but you can't tell me that insulin didn't work. They just didn't take enough. So failing insulin because it wasn't saturated. People usually need 0.4 units per kilogram. So a 220-pound person, 100 kilograms, needs about 40 units of basal insulin. All right, what about self-monitoring of blood glucose? This is just my opinion, but I think most people agree with that. When you have people on these medicines that don't cause hypoglycemia, and that you're not making multiple decisions during the day on what dose, and if their glucose is well controlled, they can do a fasting blood glucose once a week. Okay, you don't need to have people sticking their fingers 4 times a day because they're on metformin. If the glucose is not well controlled, then I would have them do a fasting blood glucose 3 times a week, and then 1 day each week do a pre-lunch, pre-dinner, and bedtime, just so that you get a pattern. Because you can't really make good medication choices unless you know when the glucose is high, what their pattern is. The people that are well controlled on these don't need to be doing finger sticks unless they say it really helps me with my food choices. Some people say, "I like to do it because I know if I eat this and I see that my blood sugar goes high, I won't do it again." So if people want to do it, fine, but I usually don't make people do more than 1 a week if they're on these medications. Okay, continuous glucose monitoring. When you want to think about this, anytime you're looking at a person, their glucose is not well controlled, but you don't know what to do because you don't know what their glucose pattern is. If you need more glucose data in order to make therapy decisions, that's when CGM is going to be helpful for you. So I'm just going to show you a little bit of data. This is professional CGM. Professional CGM is like a Holter monitor. You order it, you do it, it sends you the data back. And this is type 2 diabetes, 299 people with type 2 diabetes, 25 general practices in Australia. Their average age 60, their A1C was 8.9. These the flash CGM, the Libre, versus usual care for 12 months. Their initial A1C came down at 6 months. Their time in range improved. That was statistically significant. So this is a group of type 2 patients that were just put on professional CGM once every 6 months, okay, per week. Didn't have to buy their own CGM, but the doctors got a lot of information on what to do. So CGM helps reduce the risk of ketoacidosis. This is a retrospective chart review of people with type 1 and recurrent DKA who initiated Freestyle Libre for 20 months, 24 months. This is DKA and severity. Total DKA was reduced significantly. Mild, moderate, and severe were all decreased. There's multiple studies that have shown that CGM reduces the risk of developing DKA and hospitalizations for it. What about other complications? This was a study of people that 74,000 people were type 2 or type 1. The data I'm showing you here is for type 2 diabetes. DKA was reduced, hypoglycemia was reduced, being admitted with a diabetic coma was reduced, hyperglycemia was reduced, total complications were reduced. So CGM has good data, and this is just on acute hypoglycemia. I won't show you, that's pretty blurred, so I'm just going to summarize that. Hospitalizations for people with hypoglycemia who had normal awareness or impaired muscle awareness was significantly reduced at 12 and 24 months. Comas were reduced, and third-party help was reduced. So we have really good data that CGM reduces the acute complications of diabetes, DKA, hypoglycemia, and hospitalizations. So professional CGMs, remember, these are provider-owned. You can get these in your own clinic. Sean Usser has them down in his clinic. And you can get those for yours. We have them. You can send a referral to us. We loan these out for 7 to 10 days. They check the glucose value every 5 minutes. They come back. They can either mail their sensor in or come back in. We download those and look at the analysis. These are the two that we use in our clinic. Personal CGMs, we have 4 different ones. We have a Dexcom G7 and 6. We have Freestyle Libre 3, Guardian, and Senseonics. This is implanted in the forearm and stays there for 3 months. They're trying to make the Senseonics last for 1 year, but these still have to do finger sticks today, and so does the Guardian, whereas the Dexcom and Freestyle Libre are factory calibrated. People don't need 3 finger sticks anymore on the Dexcom and the Freestyle Libre. The new Guardian 4, they say that's true of it, so we'll see. So, just to show you how useful CGM can be, I went on vet literature and found that it's commonly used in dogs and cats and other kinds of animals. So we need to get with it. It's even used at the zoo and so if you're not using CGM, just to show you that it is under common use. How do you order these? Type in glucose in the order box. Click on glucose monitoring, 72 hours. It's actually 7 days, but the epic is wrong. So 72 hours, Q sensor. If you don't have one in your clinic, type in AMC, endocrine LP, that will send it to us. Accept and sign it. Type diabetes into the order block and put an ambulatory referral to our adult diabetes head. And just put in this information. That'll send to us. We'll call the people. We'll do a professional CGM. We'll interpret that data and send it back to you.
Mike, I have a question. I've had patients who don't have diabetes but on the CGM because they want to know if by chance increase their glucose or their anti-diabetes. Constant increases their glucose, but not the end glucose, and they're worried about these glucose excursions, but they're normal glycemic. Any reason to do that?
There's not. There's a lot. The big thing right now that endurance athletes are using these, runners and bikers. They don't have diabetes. They're just trying to. I don't know what benefit it is to them, but they monitor their glucose and what effect does it have if I go up this hill as hard as I can? What if I take this gel?
Yes.
And so a lot of people are using it. It's fine. They have to pay for it. Only covered by insurance. I don't see a particular benefit for it. They're also given to a lot of people that have, reaction to hypoglycemia. But these are not that accurate after you get below 70. They're good to tell you you're below 70, but they don't really tell you where you are. So I'm not convinced that that's a good use for me either. Although I see that quite often. But yeah, if people are just curious about how healthy they are, but if you ate cinnamon roll and you make insulin normally, your blood sugar really shouldn't go up very much. So I'm not sure that would keep you from artichokes, So if people are on multiple daily injections, and you want to order it a personal CGM, so you have a patient that says, I'd like to have my own CGM. If they're on multiple daily injections, you need to put this phrase into your chart. So I'm just gonna, this will be on the handout, okay, that I'll give to you. I made a smart phrase for this, CGM on MDI, and I popped that in there. And you have to put in, there's a hard stop there, how many insulin injections do they do per day? If you put this phrase in, you can get personal CGM approved for somebody on multiple daily injections. And you send that prescription to their pharmacy. If they're on an insulin pump, there's a different phrase, it just says they're on an insulin pump. But if you're interested in ordering personal CGM for people, copy these phrases, make a smart phrase for yourself. So you can put it in your how do you bill for the interpretation? So if you order a CGM or a person on personal CGM comes into your clinic, you download their data or you download it from the cloud, which is what I recommend, Dexcom Clarity. You can actually bill for that. The bill is $225 to do that. You need to put in this CPT code, and you need to put in a 25 modifier if you do that during the visit. We document it in the chart using this wording and just make this a smart phrase. It says, you download CGM, here's my interpretation, here's my recommendation. Then you click which one of these applied. Okay. Again, I'll make all these slides available to you, but then you can bill for those, and they bill out at $225 for a week. CGM interpretation, you want to look at the time and range. You want to look at the pattern, and then you want to make some management recommendations. Okay, so first of all, time and range, when you do a CGM, it'll tell you how much time they spend below 54, how much time below 70, how much time in the target range, 70 to 180, how much time above 180, how much time above 250, and what percent of their time they're actually wearing their CGM. So these are the targets, and most people have less than 5% of values greater than 250, less than 25% greater than 180, over 70% in the 70 to 180 range, less than 4% under 70, less than 1% under 54. Older people, higher risk people with frequent hypoglycemia or cardiovascular disease, those goals are a little bit more conservative. And so you can use that when you have someone coming in and you don't have an A1C, you can say that you're really in target range all the time, and most of the time. Then, when you're looking at their patterns, look at their trend overnight. Look at how much they go up after each meal, when their blood glucose levels are high, when they're low, and when is it most variable. So here's a 62-year-old man with type 2 diabetes for many years. He has end-stage renal disease, he's had a transplant, he's got retinopathy, peripheral neuropathy, and CAD. He takes Glargine, 16 units. There's his professional CGM, so we order a professional CGM from him. His GMI, so what's a GMI? Glucose Management Indicator. That's the equivalent A1C for the past 2 weeks. When you've got glucose levels every 5 minutes, you can extrapolate the past 2 weeks into an A1C. When you've got somebody that the orthopedics won't operate on them until their A1C is under 8, you say, oh, now I got to wait 3 more months to get an A1C. You can get a professional CGM, and if that GMI is under 8%, you say that is equivalent to A1C. So the glucose management indicator is their 2-week A1C equivalent. And so here we have somebody that's dropping, significantly overnight, having still waking up elevated, having a big excursion after breakfast, not doing too much after lunch, and then having a modest excursion after dinner. So what would we want to do? We would want to try to cover this meal. I think this guy needs some short-acting insulin to prevent that increase. He needs some short-acting insulin for dinner. And then his blood sugar will be about here. If we don't want that blood sugar dropping dramatically overnight, we're going to need to reduce basal insulin so he doesn't get hypoglycemia. So you can see when you see a 24-hour pattern, you can make some very well educated decisions. Here's just somebody with a personal CGM that again drops overnight, weight increase In this case, after lunch, another big increase after dinner. So we would want to increase the list pro at breakfast, at lunch, and dinner, decrease the basal insult overnight. And just one more, just showing you another pattern of someone who goes up a little bit after breakfast, not too much after lunch, too much after dinner, and then a drop overnight. So you can see these patterns and they help you make good decisions with what they have. The last thing I just wanted to mention to you is automated insulin deliveries or hybrid closed loop systems. And this is where a Dexcom and now, as of this month, the Guardian 4 send information to the pump and tell it what to do. So these are hybrid closed loop. They don't cover meals, but they regulate the basal rate, you have automatic correction doses. So if you have people with type 1 diabetes or somebody with type 2 for whom insurance will cover it, we do a lot of this, these hybrid closed loop systems, and we see people with amazing control coming in every day. A1C is 6.5, glucose management indicators 6.5, no hypoglycemia. So if you've got people that are really interested in technology, you've got some technology that can really help you know. So let me stop here. You had some questions along the way, but if you have any more, I'll be glad to answer those.
There was a study I saw in Journal Law, the summary. I think it compared after metformin, GLP-1, SGLT2, or sulfonylurea, and they were equivalent. Do you know that study? And you know, I was surprised at myself, because I always never
I'm not familiar with it, but and it depends on how long it is. You know, the GLP-1 reductions that we see are more long-term because you're combining significant weight loss with improvement in glucose control. And it also, how much A1C reduction you get depends on where you start. A lot of studies, you know, look at people having A1C between 7 and 8. And in that range, a lot of people are going to have similar reductions no matter what you put them on. And the sulfonylureas work. I can't, you know, and they're inexpensive. It's just that 1/3 of people don't respond to sulfonylureas. 1/3 of people respond initially and stop responding, and then 1/3 it works forever. So it's a good way to think of it because hypoglycemia.
Is weight loss similar for oral GLP, Rybelsus compared to the injectable GLP?
It's about the weight loss with Rybelsus is roughly what you see with the middle doses of the injectables. So like Ozempic, you go up to 2 milligrams. It would be similar to maybe what you get with 1 milligram. Okay, with 1.5 with Trulicity, there's a 3.0 and 4.5 dose. So it's sort of the mid doses of the injectables, but is what you'll get with doses.
That reminds me, I've had people who work out to the 2 milligrams and 2.4 on Wegovy, and they're now they actually have a normal BMI and they're still losing weight. You back off. And
Depends on what your goal is, but you can back off and try to stabilize the weight. You had a guy call us and said, I've lost so much and I want to stop losing.
Yeah.
But I'm glad it's under control. So we just backed off on this dose.
Yeah.
Yeah.
So there's been so much speculation about the obesity epidemic and like it being more than just energy balance, changing diet patterns. And one, is there any evidence of that? And it seems to me that with the degree to which the medication is somewhat correct, is there any evidence, for example, that's the changes in the endocrine system or?
So, no, I think the biggest area that I see that, is looking at the microbiome in people with obesity. There's clearly differences in obese versus thin people. And they've taken the microbiome samples out of thin rats genetically thin and put them, give them a different microbiome and they gain weight and vice versa. So I think the microbiome might be, one answer to the, is it just energy in and energy out? Does your microbiome somehow heat up some of your calories or increase your metabolism somehow? But I haven't seen anything that the incretin system is defective. It certainly ought to be investigated because it still just baffles me why some people are just chronically overweight. Other people are chronically thin and you know, skinny people that just eat like crazy, and they just skinny, you know, and so there's gotta be an answer to that, but, it is, you know, energy balance, so energy in versus energy out. And what is your brain, you know, how does your brain equalize that? Does your brain really send how many calories went in and tell you how much calories to use up? And there may be some affected signaling in that regard. And just very small amount imbalances in calories per day add up over a year. You know, so I think that we still are not fully understanding why we have such an epidemic of obesity, but I do think the microbiome is promised.
Just a question on Zoom. We've had several patients come to their weight loss doctor recommending once monthly injections and semaglutide for maintenance. Any evidence that it's useful or any experience with that?
I don't have any experience with that at all, and I don't know of any evidence. You know, I'd like to see evidence. I mean, it makes sense. You know, they say that when you stop the GLP-1s, many people will regain weight, but not everybody does. The term mission of diabetes came about because we were seeing people that lost weight and got their A1Cs down so much that they were able to stop their medications, and a certain percentage of those people remain in remission with low body weight, you know, permanently. So I don't think it's a given that everybody's going to regain. But if they're going to regain, I would start them back just on the regular program. But, you know, I haven't ever tried something like that. It could be reasonable, but I don't know why that would work. I mean, it's going to wear off after a week that you're going to have 3 weeks without GLP-1 effect. So it's a nice plug. If there was data to support it, I think that would be interesting, but I don't know.
Great. Thank you very much.